Hi all, welcome to the weekly NDAC webinar series. I'm Amy Peacock, a researcher at the National Drug and Alcohol Research Centre, and I will be the chair of the session today. Before I start, I would like to acknowledge the traditional custodians of the lands throughout this country we know as Australia. I'd like to pay my respects to elders past, present, and extend that same respect to any Aboriginal or Torres Strait Islander people here today. So we're in for an exciting session today. Today, we're going to be hearing about vaccine uptake among people who inject drugs, the pandemic and beyond. As we all know, vaccines are important to protect the health of all individuals, but they can be particularly important for people who inject drugs who may be at heightened risk of vaccine preventable diseases. In this webinar, we're going to be hearing about the current evidence on vaccine coverage among people who inject drugs globally. And then we're going to focus in on Australia and learn more about attitudes towards and uptake of vaccination in Australia among people injecting drugs, focusing specifically on COVID-19. I'm absolutely delighted to present our speaker on this important topic, Olivia Price. So Olivia is a PhD student at the National Drug and Alcohol Research Centre. Prior to undertaking her PhD, she worked in infectious disease surveillance at the Doherty Institute and then on the Drug Trends program of work at NDAC. Her primary research interests will come as no surprise. They are focused on the prevention of infectious disease among people who inject drugs. I'm also delighted to introduce our panelists for today. So Olivia is going to be joined by two key collaborators and experts in this area. We have Professor Greg Dorr, head of the Viral Hepatitis Clinical Research Program at the Kirby Institute at UNSW, and infectious disease physician at St Vincent's Hospital, Sydney. We're also joined by Sione Crawford, Chief Executive Officer of Harm Reduction Victoria, an organisation which represents people who use drugs in the state. We're going to have plenty of time at the end for questions for Liv and our panellists, so please do send them through. I'd ask you to post them in the Q&A function, please not the chat, and I will present them to the panel at the end of the presentation. As always, unfortunately, I may not be able to present all of them, but I'm going to give it my best shot. So, no more from me. I'd like to invite Liv to turn on her camera and kick off the presentation for today. Thanks, Liv.
Thanks, Amy, for the introduction. I'm really excited to be presenting some of the work we've been doing on vaccine uptake among people who inject drugs. But I'd just like to start by acknowledging the Gadigal people of the Eora Nation, who are the traditional owners of the land of which I'm zooming in from today. I acknowledge their continued connection to land and water and pay my respect to elders past and present. And I'd also like to extend that respect to any Aboriginal or Torres Strait Islander people who may be zooming in today. And also to continue the acknowledgements, the work I'm presenting today has formed the first part of my PhD. So I'd also like to just give a shout out to my supervisors, Professor Louisa Degenhardt and Associate Professor Amy Peacock, for their support in this work. So vaccines are one of the most cost-effective and successful ways to prevent disease, but we know that there are disparities in access to vaccination. And this issue of equitable access to vaccination is a real public health issue. Vaccines become far less effective if we're not reaching everyone with vaccination, and understanding if there are some groups in particular who are missing out is crucial. Because this has implications for the health of the individual who's not vaccinated, but also if we see populations who are systematically missing out, this has implications for the spread of disease within those communities and therefore for population health. So over the next few slides, I just want to introduce why people who inject drugs are an important population to ensure we're reaching with vaccination programs. And for the purpose of this presentation, I'm going to focus on diseases for which vaccination is clinically relevant for people who inject drugs. So a disease for which there is an adult dose recommended, or for which people who inject drugs might be considered at high risk for. So these are listed here on the slide: hepatitis A and B, influenza, tetanus, pneumococcal disease, COVID, and human papillomavirus, or HPV. So firstly, in terms of what we know about the burden of vaccine preventable disease among people who inject drugs, It's hepatitis B that we know the most about because of its potential for transmission via contaminated injecting equipment. So the most recent estimate is that 1 in 12 people who inject drugs globally have a current hepatitis B infection, but there's quite wide geographic disparity in this. So that ranges from about 1 in 50 people in Western Europe up to about 1 in 6 people who inject drugs in East Asia. For the other diseases of interest, we have far less evidence on the burden of disease, but there have been observed outbreaks of hepatitis A and clusters of infection of tetanus. We also know that the incidence of community-acquired pneumonia is 5 to 7 times higher among people who inject drugs than the general population. And there's increasing evidence of a higher seroprevalence of COVID, especially from the US, among people who inject drugs. But we have no evidence for the burden of disease for influenza or HPV. But the main point I want to make on this slide is that overall it appears people who inject drugs might experience a higher burden of vaccine preventable disease. And for some of these diseases, including hepatitis B and tetanus, there's a clear link between injecting drug use and infection. But for the majority of these diseases, the increased risk of burden is more about the intersectional risk environments that people who inject drugs might experience, including things like unstable housing and exposure to sex work. There's also a number of factors that we believe may cause people who inject drugs to be more susceptible to severe health outcomes following infection with a vaccine preventable disease. So we know that there's a high prevalence of comorbid health conditions among this population, including chronic respiratory disease and also cardiovascular disease. And there's also sort of emerging evidence that chronic substance use is associated with sort of an accelerated physiological aging process, which might also leave the population more susceptible to more severe health outcomes. And finally, we know that people who inject drugs experience barriers to healthcare, and this is driven not only by social determinants of health, but also the experience of stigma and discrimination. And these barriers, which might lead people to delay or avoid seeking healthcare and therefore experience poor health outcomes. So in terms of vaccination for people who inject drugs, the EMCDDA does recommend vaccinating people who inject drugs for hepatitis A and B, tetanus, flu, and pneumococcal disease. But we also know from the literature that people who inject drugs experience structural barriers to vaccination, which may result in gaps in vaccine coverage despite these recommendations. And these barriers include things like healthcare provider discrimination, low socioeconomic status or poverty, and distrust of healthcare or other institutions. But what we don't know is how many people who inject drugs are vaccinated for each disease of interest. And this is quite a critical knowledge gap. If we have a better understanding of vaccine coverage among this population, it can tell us whether the coverage is sufficient enough to prevent transmission of disease among communities, and whether these recommendations for vaccinating people who inject drugs are actually being enacted, and identifying specific vaccines or countries or regions with low coverage can enable the best and most efficient direction of resources to improve vaccine coverage. And the other knowledge gap that I want to address today is access to vaccination during a pandemic. And we know that the pandemic exacerbated existing health inequities. So understanding whether that extends to vaccine coverage during a pandemic is really important. So today I'm going to be presenting sort of the beginnings of a program of work that aims to improve our understanding of access and uptake of vaccination among people who inject drugs. So firstly, I'll present and discuss what we currently know about vaccine coverage among people who inject drugs and where the gaps are. And then moving to focus on COVID vaccination, specifically in Australia, I'll be addressing attitudes towards the vaccine early on in the rollout in 2021, and then uptake of vaccination among people who inject drugs a year later. And then finally, at the end of the presentation, I'm going to attempt to bring all these different studies together and talk about the implications that they have beyond the pandemic. So I'm going to start with our systematic review on vaccine uptake among people who inject drugs globally. And this is still preliminary work. It's not finished yet, but I think it gives a good interview into the current status of the data that we have available. So the systematic review involved 2 systematic searches of the peer-reviewed and grey literature. The first search was part of an umbrella review that aimed to return all studies that reported demographic or drug use characteristics or disease prevalence among people who inject drugs. And then the second search aimed to specifically look for vaccine papers in case those were missed in the first search. Studies were date limited from 2008 to present, and we also received some additional data from international agencies, including the UNODC and WHO. So basically what we were looking for was any study or report that reported the proportion of people who inject drugs who were vaccinated against one of those 7 diseases of interest. And in general, vaccine coverage data is collected using 3 different methods that vary quite a bit in their reliability. So self-report data is naturally the easiest to collect, but this is really offset by its lower reliability of accuracy, although this does differ by the disease. Serological data is good for some diseases, including hepatitis B, but not for others where you can't distinguish between immunity from vaccination or infection, including hepatitis A. And then medical record data is also quite a good source of data, but this requires identification of a participant to link with an immunization registry, which is not often done in surveys of people who inject drugs due to ethical or privacy concerns. We then used the Joanna-Briggs checklist to evaluate the quality of evidence of the available studies. And to estimate pooled vaccination coverage, we used random effects meta-analysis weighted by people who inject drug population size in each country. So on this slide, basically the main thing that I want to point out is that we get the 3 searches returned, there were 2 searches done for the first search strategy in 2017 and 2022, and then the vaccine search specifically. And those 3 searches returned almost 90,000 studies, but only 78 had the data that we were looking for. In terms of geographic coverage of the data available, they covered 36 countries, the majority of which were high or upper middle income countries, and there were no data for any low income countries for vaccination coverage. And then on this slide, I've just shown the geographic coverage by disease of interest. Sorry about the tiny maps. But the main thing I want to point out is that hepatitis B made up the majority of estimates. So of the 121 available estimates, about 2/3 to 3/4 were for hepatitis B. And so naturally, hepatitis B had the greatest geographic coverage of estimates. And then it was the United States was the only country that had an estimate for each of the vaccines available. In terms of quality of evidence, it was quite mixed. Half the studies were rated a low risk of bias, and the main issues with the evidence available was that there was quite a high reliance on self-report data. Also, vaccination was rarely the primary outcome of a study, which precludes subgroup analysis. So we can't necessarily pool estimates by characteristics of interest like gender or age. And there were some issues with sort of clinical relevance in the way that vaccination was reported. So for example, a lot of studies reported whether participants had received at least 1 dose of hepatitis B vaccine, but we know that at least 2 or 3 doses are required to elicit a protective immune response. And also in studies that reported influenza or tetanus vaccine coverage, a lot of studies reported lifetime dose, which is also less relevant given the need for repeated vaccination for these diseases. So with the data that was available, we were only able to pool global coverage estimates of vaccination for hepatitis B and hepatitis A. So for hepatitis B, we pooled the data separately for serology data and self-report data because there are known differences between the 2. So globally, we estimate that just over 1 in 4 people who inject drugs have serological evidence for for immunity generated by vaccination, but there's substantial regional variation in coverage. So this ranged from about 10% in South Asia to about 60% in Western Europe. And then using self-report data for hepatitis B, we estimate that about 1 in 5 people who inject drugs has received at least 1 dose of the hepatitis B vaccine. And then for hepatitis A, we estimate that between 1 in 4 and 1 in 5 people who inject drugs self-reported vaccine for hepatitis A. And I also just want to very briefly point out the quite wide confidence intervals around these estimates, because this is indicative of both the high heterogeneity of the estimates we had available. So they varied quite widely by country and by region. And it's also indicative of the limited number of studies we had available to be able to pull these data. So it just shows that the limited amount of data means we can't be overly confident in these estimates. So to summarize our findings from the systematic review, the key takeaway is that we just have insufficient data available to gain an accurate understanding of vaccine coverage among people who inject drugs. And we really need better data in terms of better coverage for the different vaccines, better geographic representation, and representation from countries that are low or lower middle income. Although the available evidence was limited, it's still clear that there's suboptimal vaccine coverage among people who inject drugs, although there was some quite obvious regional variation. We do have many evidence-informed interventions that have been shown to improve uptake and completion of vaccination series, including things like combined hepatitis A/B vaccines, accelerated hepatitis B vaccine schedules, financial incentives for vaccination, and co-location of immunisation services at low threshold services like needle syringe programs. But these require dedicated funding to the organisations that are best placed to serve this population. And then in terms of limitations of the review, many studies relied on self-report data, which really does impact the reliability of our estimates. And the majority of data came from high or upper middle income countries. So it's possible that we're overestimating global coverage, given that these made up the majority of data. So now I want to focus on the COVID vaccine, particularly uptake of it within people who inject drugs in Australia. And so this study was driven by preliminary research prior to vaccine rollout in Australia that suggested there was higher COVID vaccine hesitancy among people who inject drugs than the general population. And we did this study because we wanted to know if that was still true after vaccine rollout had commenced. And we wanted to explore more in depth the different attitudes around the vaccination. And then we wanted to see if there were particular settings that the vaccine could be delivered in, or particular factors that might increase people's likelihood to get the vaccine. So to do this study, we used data from the illicit drug reporting system interviews. And this is a study that includes annual interviews with a sample of people who regularly inject drugs. And the study is designed to identify emerging trends in drug use in markets. So we don't consider this sample to be representative of the broader population of people in Australia who inject drugs. To be eligible for the study, people are at least 18 years of age, report injecting illicit or non-prescribed drugs at least monthly in the past 6 months, and reside in an Australian capital city. And we recruit participants from low threshold services, including needle syringe programs and via word of mouth. And these interviews were conducted between June and August in 2021. So just quickly to talk about sample characteristics, the majority of the sample identified as male, the mean age was in the mid-40s, and the majority were stably housed and not currently employed. And in terms of health and drug use, about half reported a chronic health condition, about 37% were currently in drug treatment, the majority of which is opioid agonist treatment, and methamphetamine and heroin are the main drugs injected. And I think with these data, it's really important to remember where we were in the pandemic when we asked people if they intended to be vaccinated. So here in the yellow box is the interview period, and it's superimposed on the daily case numbers at the time. So the interviews occurred about 4 months after the vaccine rollout commenced, but it was still in that time where the rollout was being phased out, and it was really only available to priority workers or people in risk groups. And around this time, there'd also been some mixed messaging from the TGA about vaccine safety, which caused a bit of confusion. And I also want to point out that within the interview period, there was also a lot of change. So by the end of the interview period, most of the eastern states were in lockdown, and the Delta wave of cases had begun. But it was sort of before that realization that vaccination, rather than elimination of cases, was the way out of lockdown. So with all that in mind, we asked people if they intended to receive the COVID vaccine, and 10% had already been vaccinated, and 42% indicated that they would be vaccinated. And then we considered the remaining 48% vaccine hesitant. And among those participants, the key barriers related to concern about vaccine safety and side effects. And also quite relevant to the time of the pandemic, there was sort of a bit of a perceived low risk of getting COVID, and also a belief that COVID wouldn't be that serious if they did get it. And at this point, the hesitancy among this sample was higher than representative surveys of the Australian public, but the barriers were quite similar to those cited in the Australian public surveys. But then we wanted to look further into this group that we had called hesitant, because there's a lot of broader vaccine hesitancy literature that suggests that dichotomizing people into either hesitant or acceptant can be quite reductive. And what we really see is more of a spectrum. And it's important to understand where people fit on this sort of spectrum, because presumably people at different points require different interventions to get them vaccinated. So to investigate this, we used an analysis approach called latent class analysis. And this is a case-centered approach to answer a research question that allows us to organize observable characteristics or survey questions into groups of people that aren't necessarily observable. So what I mean by that in this situation is that you can't just ask someone where they fit on this spectrum of vaccine hesitancy, but what you can do is ask them questions that you know represent key constructs of vaccine-related beliefs. So the questions that we asked people were about their attitude towards the COVID vaccine, attitude towards vaccination in general, their trust of COVID information provided by the Australian government, and their perceived severity and susceptibility of disease. And each of those 5 questions had 5 possible responses that went from 1, most accepting, to 5, least accepting or most hesitant. So the results of this analysis are here, and I'm going to try and explain this the best that I can and not spend too much time here. So what we did was we chose the 3-class model solution, and this was informed both by model selection criteria and the literature. So we came up with 3 groups that we called vaccine hesitant, vaccine acceptant, vaccine hesitant, and vaccine resistant. And this is a heat map, so the darker colors indicate a higher probability of endorsing that level within a question. And within each of these classes, from left to right, it becomes more hesitant. So the first thing I want to just point out is that you can see that in the acceptant group, the darker colors are clustering towards the left in the least hesitant. In the middle hesitant group, they're sort of in the middle, and in the resistant group, they're on the right. The other thing I want to point out is that across the board, the perceived susceptibility to COVID was just low in general, which I think speaks to the time that we interviewed participants in. And the third thing I want to point out is that this general attitude to vaccination, which was framed as, in general, how much do you support vaccination, was actually quite mixed in this group that we called resistant. So although they were less likely to support vaccination than the other 2 groups, I want to demonstrate here that they weren't just an anti-vax group in general. And we had originally called them vaccine rejecting and changed it to resistant because of this finding. So then we were interested in knowing or understanding whether there were differences in characteristics between these groups to understand whether certain groups of people may require certain interventions. So compared to the acceptant group, both hesitant and resistant participants were more likely to be younger, reside in unstable housing, and have not received the current seasonal influenza vaccine. And none of these results were overly surprising. Younger age likely points to a lower perceived severity of disease. Unstable housing presents a structural barrier to vaccination, and receipt of the influenza vaccine is indicative of other healthcare access. The hesitant group were less likely to have a chronic condition that indicated them for priority vaccination, which is a good news association, because if you flip it, it means that the people who were vaccine acceptant were more likely to have a chronic condition and more likely to be vaccinating, again, probably relating to their perceived severity of disease. And then the resistant group were more likely to predominantly inject methamphetamine compared to heroin, which is a result we see in other studies of health-related outcomes of people who inject drugs, including the hepatitis C cascade of care, and may indicate lower engagement with primary health care than those who use heroin. And the vaccine-resistant group were also more likely to inject drugs more frequently. We then asked these participants whether there were certain settings for vaccine delivery or other factors that might increase their likelihood to be vaccinated. And here you can see the probability of endorsing each factor based on the class that they were in. So pretty quickly, what you can see is that the hesitant participants who are in the purple color across the board were more likely to indicate that something would make them more likely to be vaccinated. Compared to the resistant participants who are in orange. And this wasn't really a surprising result. Marginally, the hesitant participants were more likely to endorse factors relating to improving trust in vaccination. So side effects proven to be minimal, or a trusted health professional recommends vaccination. And then across the two groups combined, it was financial incentives to be vaccinated that were the most likely to be endorsed. So in summary from this study, firstly, we found that vaccine hesitance and resistance were quite prevalent among this sample of people who inject drugs. But based on their attitudes towards vaccination, it's not a homogeneous population, which means that there might not be a one-size-fits-all intervention to improve vaccination. There are specific subpopulations that require intervention, so particularly people who are unstably housed and people who predominantly inject methamphetamine. Building trust in vaccination is particularly important to get people vaccinated, and financial incentives could improve vaccine uptake among people who inject drugs. And given the consistent association with flu vaccination, co-delivery of the COVID and flu vaccines could be a cost-effective way to protect the health of people who inject drugs. In terms of limitations of this study, firstly, it's cross-sectional, and during the pandemic, people's attitudes and behaviours changed so quickly with rapidly evolving information and changes in the pandemic. This is quite a service-engaged sample, so they might be more likely to receive the vaccine than the broader population of people who inject drugs in Australia. And there's also limited nuance in this structured survey. So it would have been really great to do a qualitative study where we could really examine people's attitudes towards vaccination in more detail. And I just wanted to direct you, if you want to read any further about the information in that study, there's 2 studies published in Drug and Alcohol Review that you can read. So now moving on to the last study. So this study was driven by the results of the study that I've just described, and this occurred a year later. So we were interested to know, given this high level of hesitance and resistance towards vaccination, what vaccine uptake actually looked like sort of 18 months into vaccine rollout in Australia. So we used the same, we used interviews from a year later in the same reporting system. And it's important to note that the study is repeated cross-sectional in design, so people can participate in multiple years, but this isn't the same sample of people that we spoke to about their attitudes the year before. But because we recruit people from similar settings and using similar methods, we do consider them comparable. So these interviews were conducted about a year ago, May to July 2022, and we see similar socio-demographic characteristics and drug use characteristics to the sample from the year before. This is, again, a timeline of when we interviewed people. So we asked them whether they intended to be vaccinated in June to August 2021, and then a year later, whether they actually did get vaccinated. And in the meantime, there were 2 booster doses recommended, and we also had that Omicron sort of era of far higher community incidence than we'd seen in 2021. And what was a good news story was that we saw 84% of our sample receive at least 1 dose of the COVID vaccine. And when you break that down by the number of doses they had received, 46% had received at least 3 doses. So they had had at least 1 booster dose. We then wanted to compare uptake of the primary course, so uptake of 2 doses to Australian population coverage estimates. So we generated age and gender standardized prevalence ratios and stratified the results by 40 years of age because vaccine recommendations differed by age. But you can see across the board for both men and women of both age groups that vaccine uptake was sort of 15 to 20% lower than Australian general population estimates. So yes, much higher than we expected given our interviews from the year before, but still a little bit lower than what we saw among the Australian general population. Given the high hesitancy in the previous year, we were interested to know among people who did end up getting vaccinated, what their reasons for getting vaccinated were. So the top-cited reason was to protect myself from COVID, and then the other side, most cited reasons were to protect vulnerable people from COVID and to be able to go to venues, so speaking to those vaccine mandates. And then in terms of barriers to vaccination among those people who were not vaccinated, similar to what we had seen the previous year, safety and side effect concerns made up the most cited barrier. But that lack of concern about getting COVID or believing that COVID wasn't a serious disease were no longer evident, but instead you can really see the institutional distrust becoming a real driver to not getting vaccinated. So then again, we were interested in understanding the characteristics of people vaccinated compared to those who weren't vaccinated so that we could identify subpopulations who might be missing out on vaccination. So firstly, we compared people who had completed the primary course to people who had not received any vaccination. And then we were interested in knowing what the differences between people who had completed the primary course and people who had then gone on to receive at least 1 booster dose. So there were, again, similarities across both comparisons. And again, we saw that receiving the seasonal influenza vaccine was associated with receiving a COVID vaccine, and trust in the government and perceived disease susceptibility. So believing you were more likely to get COVID was associated with getting the vaccine. And then compared to participants who hadn't received any doses of the vaccine, people who had completed the primary course were more likely to be stably housed, engaged in COVID testing, and currently prescribed opioid agonist treatment. So those are similar results to what we had seen in our previous study about attitudes towards vaccination. And then looking at the differences between people who had received at least 1 booster dose and people who had only received the primary course. Those people were more likely to be older and have a chronic medical condition. And so those results really mirror the national recommendations for vaccination. So to summarize this study, overall we saw higher vaccine uptake than expected given our previous work, but there is still a bit of a gap between coverage in this sample and general population coverage. I think it's important to think about what changed over that year, and we know that there are a lot of community-led vaccine delivery or education interventions that were integral in maximising vaccine uptake among this population. It's also possible that the increased community incidence of disease made people more likely to get vaccinated, and vaccine mandates may also have played a role, although this represented a minority of the motivators among our sample. I think interestingly, factors that were associated with any uptake of vaccination related more to service access and structural barriers. So people in opioid agonist treatment who are more likely to be engaging in primary health care, and people in stable housing were more likely to have any vaccination. And then when looking at the differences, or when looking at the factors that were associated with booster dose uptake, these were more likely to reflect the national guidelines. So I think this really reiterates the issue or the role of structural barriers in getting people vaccinated in the first place. And then finally, I think, and really importantly, the main motivations for vaccination among this group, which were to protect myself from COVID and to protect others from COVID, really challenges this narrative that people who inject drugs are reckless with their health. So some limitations of this study: we don't know participants' vaccine eligibility status. So when we compared people who had received the booster dose versus who hadn't, we don't actually know at what point they had been vaccinated and therefore whether or not they were actually eligible for the booster dose at that time. We also didn't ask participants about barriers to booster vaccination, and these are likely to differ from barriers to any vaccination. And again, this is quite a service-engaged sample, so we might be seeing higher uptake among this group than the broader population of people who inject drugs. So now, just to wrap up the presentation, I want to talk about these three studies together and what they mean as we move beyond the pandemic. Okay, so I think probably the key takeaway from the three studies is that vaccination is often neglected in harm reduction responses or health responses for people who inject drugs. And this is really evident in the systematic review, where there was limited data on vaccine coverage and also suboptimal vaccine coverage for the diseases that there were data available for. But even though we know from the systematic review that vaccine coverage is low, the really, really high uptake we saw for COVID vaccine in our sample in Australia, which has also been shown in recent studies from the US, this suggests that the low coverage for other vaccines isn't due to sort of an anti-vax sentiment among this group or a neglect for their health or any sort of desires to not be vaccinated. I think what it really shows is that we can modify this low vaccine coverage if it's done appropriately. Our findings also show that vaccine uptake and access to vaccination is really driven and affected by social determinants of health. So we saw that association with housing and vaccination uptake, and other studies have noted associations with food insecurity and unemployment as barriers to vaccination among this population. And this is a bit of a recurring theme in public health. If you saw Amy's presentation last week on drug overdose deaths in Australia, it's also social and structural factors that were a key risk factor for drug overdose mortality. And these kind of issues require sort of urgent and systemic action, and improving these kind of aspects of people's lives will improve vaccine uptake, but so much more than that as well. And then the strong association we continue to see between vaccine hesitancy and government trust really suggests that prior discrimination in this population impacts people's vaccine decision making. Everyone has a right to access vaccination, and improving policy that relates to injecting drug use, including decriminalisation of drug use, could go a long way to eliminating this distrust seen in this population. So improving where we currently are with vaccine coverage among people who inject drugs is really time critical to ensure that we have an equitable public health system. We're starting to see an aging cohort of people who inject drugs in Australia and in other countries, and ensuring people are vaccinated, particularly for things like influenza and pneumococcal disease, is really essential for a healthy aging process. And also getting vaccine delivery to this population right now will ensure that we're best placed to deal with future pandemics and also the rollout of new vaccines when they become available. There's a lot of touch points that currently represent missed opportunities to vaccinate people who inject drugs. So providing vaccination at locations like needle syringe programs, drug treatment services, and unfortunately prisons is a good way to reach this population. And this is definitely not a new concept. In Australia, we've seen highly successful rollout of hepatitis C test and treat programs in these kinds of locations. And we knew this before the pandemic, but community-led vaccine delivery and education campaigns were so important in improving COVID vaccine uptake among this population. I've heard of examples of this work being done in New South Wales, the ACT and Victoria, but I'm sure there's many more examples from around the country of these community-led services improving vaccine uptake. And they really mitigate that institutional distrust that we kept seeing in our studies. And also by using services that people who inject drugs already intersect with, it minimizes those structural barriers to vaccination. But these solutions require recognition of people who inject drugs as a priority population for vaccination and dedicated funding to these services, which are already stretched with all that they do for the population. So just quickly, next for me, during my PhD, I'm going to look at the country factors that are associated with high hepatitis B, the country level factors that are associated with hepatitis B coverage to identify what might be causing the lower coverage in some countries. And I'm also going to use linked data to look at the burden of vaccine preventable diseases among people in Australia who inject drugs, including notifications, hospitalizations, and mortality. And these are just some ideas for some future studies, including a sero-survey of people in Australia who inject drugs to identify what diseases people are more susceptible to that could be prevented by vaccination. And I just want to quickly acknowledge collaborators from NDARC, the Kirby, Burnett, HRV, UQ, and the University of Tasmania. So many people as well on the drug trends and global reviews teams who assisted with data collection, the IDRS participants for their time, and the funders of these projects, which is the Australian Department of Health and Aged Care and the NHMRC. Sorry, I've sped up at the end there. Please feel free to email me with any questions or thoughts or information. Thank you.
Thank you, Liv. Huge round of applause. That was a very impressive program of work, considering that I don't even think you've hit the halfway mark on your PhD yet, and there's essentially a PhD there. And I think, as you just demonstrated in your first study, this work that you're doing is really addressing a key gap in the literature at the moment. I might invite Greg and Sione to turn on their cameras. And what we might do is, before we jump into the questions, and please do add more questions in the Q&A, before we jump into them, I might ask for a quick reflection on Liv's presentation, maybe just a minute or so. Sione, do you want to kick off on any immediate thoughts from what Liv's just presented?
Sure, there were plenty. Number one was I felt taken immediately back to that period in time when you were doing that presentation, as we did that actually, more so than when I was reading your slides. Thanks for that. But that is an important reflection actually when I get to it. I think the first thing I would note is that I was surprised at how poor the data is around vaccination, just generally for people who inject drugs in Australia, which is interesting. I think that links in as well to the fact that it's although hepatitis B vaccination is funded and some people who inject drugs can access it. It's certainly not, there isn't really any community engagement funded, as far as I'm aware, to at least here to engage people who inject drugs into those vaccination programs. And that's sort of consistent with some of the stuff that you said later on about what's important. And I think that is the main, I guess, reflection that I had, is that it was actually quite impressive, the uptake of vaccination in the end, as you showed. And I think that's a really good news story. But one of the reasons, as you pointed out, is because we sort of threw more or less the entire country's infrastructure behind trying to get people vaccinated. And in particular, as you said, community-led efforts, they were really intensive in some parts of the country. Obviously we were, it affected us here in Melbourne quite early on, and then everyone. And so, we sort of felt like we were able to, really focus a lot of efforts on working through some of the hesitancy factors with people, both early on and later on in the pandemic. And I think that, that has sort of gone away. And I think one of the things that we need to reflect on as a society is that if we're able to adopt sort of flexible interventions at moments of big public health panics like this, then, maybe there are lessons there for us around being more consistent with that. I think the last thing I'd say is that, and I suppose it's a good news story as well, is that a lot of the infrastructure that was put in place in Victoria anyway has hung around. So things like local public health units. I'm not sure whether it's yet to be seen whether or not those are going to be utilised well for our community, for our population of people who inject and use drugs. But there is an infrastructure there to be able to respond a little bit better in future, I think. Yeah.
Thanks, Sione. And sorry that we took you back to a place that you don't really want to go, but it's good that we can think about the positives out of that experience. Greg, from your perspective, what are the key take-homes or implications for you from what Liv's presented?
So firstly, great presentation, Liv, and just amazing sort of body of work that you've outlined. It's funny, I had very similar sort of feeling to Sione in terms of being thrust back to 2021. And it's interesting to think about the incentives that we all had to get vaccinated. I mean, it seems bizarre that there was a period of time that you could only go for a picnic outside if you'd been vaccinated. And that just shows you how weird that time was in sort of public health sense. So I think different people have different motivations for taking up sort of interventions. And I think the motivations for many people who inject drugs may have been different, and there may have been different circumstances. There's the structural barriers. But I found it quite interesting that if you looked at the booster sort of dose comparison, it was the older individuals, the people who had other chronic sort of comorbidities that were more likely to get vaccinated. So they were listening to the guidelines. In a sense, they had an awareness that vaccination was more crucial for them. And the way that attitudes sort of shifted during the sort of pandemic. So I think we talk about people who inject drugs, clearly marginalised, clearly a population that's been discriminated against, but in other ways, they're quite reflective of the broader sort of community in terms of many sort of attitudes and so forth. So I think it's really interesting to look at this from different angles.
Thanks, Greg. And that might actually lead nicely into one of the questions. And thank you so much for putting questions in the chat. Please do feel free to add more. Thank you to our anonymous attendee logging some of these. This question, had there not been a pandemic, would we have seen such relatively higher vaccination numbers among the cohorts studied or among this population more broadly? So I guess if we were introducing a new vaccine and it wasn't the heightened situation that we saw with COVID, what do you think might have happened? Maybe, Greg, if I go back to you, just given what you just said.
Yeah, look, I think it's a really good point. And if you look, for example, at hepatitis B vaccine uptake, it's pretty poor. And is that because there's a perception that it's not a high sort of risk, that not many people get chronic hep B and get severe sort of liver disease? Most people who get infected as adolescents or adults clear the virus. So would it be different if you had an effective hep C sort of vaccine? That maybe there's a stronger sort of motivation. I think it's interesting around the human papilloma virus, which is a vaccine, which has had enormous impact in terms of reducing cervical cancer and for women and genital warts for men who have sex with men. And that's a vaccine that there should be really high sort of uptake across the board, but including among people who inject drugs, and that there looks like there's a much more sort of limited uptake. So I'm concerned about that type of sort of vaccine sort of gap. So I think there are some specific areas where you're right. If there wasn't this sort of exceptionalism that there was behind COVID, and there was only a specific subpopulation that appeared to be at high risk, then what would the situation sort of be? I think it may be very different.
Yeah, thanks for that. Sione, would you add anything to that?
Yeah, just quickly. I think it's kind of a bugbear of mine, actually, a little bit, which is that it does feel a little bit like sometimes we, and I suppose in particular the Commonwealth government, tends to have a medicalized response, which is that, okay, we'll make some medications available to people, and then that's kind of it. There is then a gap I've noticed quite often. We've seen it with hepatitis B, probably the HPV vaccination as well. I know it's not fair. There are some public campaigns, but there isn't the sort of level of funding, I guess, for demand generation in community for these vaccinations. And I think, I'm kind of fairly ignorant of the HPV vaccination, and yet it doesn't take much. It even takes a few minutes of thinking about how impactful it could be for the population that we work with, and yet even with hepatitis, like I was saying about the hepatitis B vaccination, it feels like the only I've been in situations where it feels like in meetings we've been sort of told, well, the vaccination is provided. Beyond that, it's really about people wanting to take it up. They can get it from the GP. What's the problem? But we know, with all of the stuff that Liv went through during the presentation, that there are multiple barriers and multiple reasons why people, actually need to have some incentives thrown their way as to why, and not just financial, but we need to sort of do more demand generation, I think.
That's such a good point, Sione. I think extends beyond vaccination as well. Even thinking about naloxone, obviously there's an imperative there, but yeah, that education, that awareness around it as well. Moving on to another question. Liv, maybe you can address this one. Do you know how many people caught COVID in the first study and the second study? And did that motivate them to get vaccinated? Did you get a chance to look at that data?
We definitely have that data. I'm just going to try and remember it. Definitely 2021, it was less than 5 people who had COVID. And then I think by 2022, somewhere around 50% mark, maybe 40 to 50%. And there was an association with, so people were less likely, let me get this right way around, they were less likely to have had the booster dose if they had been infected. And that might speak to not needing to get the vaccine directly after you'd been infected. But yeah, very few people had COVID in that first year, the 2021 year.
Great, thanks, Liv. All right, I'm just scrolling through. We've got a few good suggestions coming through, considering potential touch points in terms of AOD treatment, residential programs, and also comments around vaccination within the prison health system as well. So on that note, I'm just looking at one of the questions. I know Libby has posted a link to an article, but maybe Greg, you can go this question. Is there any evidence about what level of financial incentives would be successful in encouraging vaccine uptake? Or anyone on the panel that has any thoughts around that?
I imagine that the higher the incentive, the better the uptake, probably. I don't know what level. For example, there's an ongoing trial that's looking at this in the context of Hep C, sort of treatment uptake, looking at like an adaptive design where you keep increasing the level of incentives to see what the sort of real point is where you have an impact. So I know there's a lot of sort of studies evaluating this in terms of attitudes around incentives. It's something where there is an emerging sort of evidence base, but to actually get public health implementation is a lot lot more difficult to get governments to really invest appropriately in trying to improve coverage of effective public health interventions. Is something that we struggle with. I don't know exactly why, but we do, and including for populations of people who inject drugs. I mean, we have some incentives for other areas, so diabetes management and various other things. So I can't see why we wouldn't be able to do that in the context of interventions for people who inject drugs.
Sorry, you go, Greg.
Just back to Liv's point about the third sort of dose and the infection, it might also be that people that are more vulnerable who've had the third dose are sort of taking additional precautions as well. And again, making those sort of choices and decisions around their healthcare.
And Sione, I'd be keen to hear from you too, because I know, yeah, obviously financial incentives is one thing you mentioned, Liv, but trust was another really big factor there. So yeah, keen to hear from you in terms of what you think could help.
As far as the incentives go, like the depending on the population, like exactly who you're incentivizing, like we tend to try and make sure that it's just about enough to get some drugs, to be honest. And I know that's not necessarily what the motivation is for most people who provide incentives, but that's just the reality of how to make sure that, you know, you're going to get people along to the thing you want them to do, because that's actually the priority for a lot of the people we work with. I think it's worth just acknowledging that. But of course, departments of health don't like providing money for drugs, but it's the reality. So as far as the rest goes, I think that trust is something that's really hard to build and very easy to destroy. And I think we did a fair amount of work near the start of the vaccination rollout in particular to try and sort of promote the vaccination if people wanted it and it was what they wanted to do, and to try and debunk, you know, myths alongside that without throwing our lot completely in with like, you really must get vaccinated, because the feelings and emotions were incredibly strong and people had really good reasons for completely distrusting the government. And a couple of Instagram posts weren't going to change that from us, right? And if we were to use up all of our capital, frankly, use up our social capital with our community on promoting something that we weren't even 100%, that most people weren't 100% sure was going to be the answer, you know, that could be a long-term bust for us. But at the same time, you know, there were all those other incentives alongside. So I think, like, for instance, getting into venues, being able to access your healthcare, because, you know, it was pretty clear that you needed to, well, there was definitely a fear that you might need to be vaccinated even just to be able to go to the shops. So I know that didn't end up unfolding for healthcare, but that was a concern. So I think that's always a matter of a number of things. And so number one might have been looking after oneself, but also I think it's really important to know that a lot of the work that we did with people was about taking care of one another, because there were people in our community who are more vulnerable to certain diseases. And so we tried to use the trust that people had in us, but also not like blow it with them, to be honest, through over promising, which I think in the end was quite a good strategy in the end, because I do feel like there was a little bit of over promising, and there's definitely been a bounce back of kind of cynicism around the vaccinations since, you know, the strategy changed, being not getting us sick rather than elimination.
Yeah, it's a complex thing, a juggling act, isn't it? And I'm just conscious of time, and Liv, that you are the speaker. Do you have any 15-second comment that you want to add on that one?
Another question?
Yeah, or about trust, about financial incentives, anything you want to jump in with? No?
No, I feel under pressure now. I think I would just say in general that prioritizing people who inject drugs in healthcare and for immunization, whether or not injecting drug use is considered a risk factor for that disease, is really important in building that kind of trust and getting people over those kind of structural barriers. Yeah, that's what I've got to
That's
say.
okay. That's your 15 seconds. Because we are on 4 o'clock, I'm so sorry I can't ask more questions. I could make you all jealous because we all got to have a bit of a chat before the webinar about this, and we could probably keep going for another hour. But thank you for those who are posting some responses and resources in the chat. Thank you to Liv. Thank you to Greg and Sione for joining us. Before we wrap, I just want to point you to the next few weeks of webinars. So next week, we have Professor Leanne Hydes from the University of Queensland on using technology to implement client-reported core outcome measures with feedback into alcohol and other drug treatment services. 25th of May, we're changing tack a little bit. We're looking at the minimum unit price of alcohol in the Northern Territory with Nick Taylor from the National Drug Research Institute. Thursday, June 8th, we have Dr. Amelia Woods from the National Drug and Alcohol Research Centre and looking at extended release pharmacotherapies for substance use disorders in incarcerated populations, a systematic review. And don't forget, for the back half of the year, we have the NDARC Symposium on the 27th of October. You can sign up now to get so much goodness in terms of the research that's being done at NDARC and in Australia more broadly. So again, thank you so much to Liv and to our panelists. Thank you for joining us, and hopefully see you next week.